Well, good afternoon, everybody. Thanks for being with us today. I am Ayami Dinkler, Chief Administrative Officer of LCMC Health, and I'm so pleased to be here. Thanks to my friends at Tulane for asking to host this really important and timely topic of talking about bias in the Tulane community and ways we're addressing it, and just the community at large in this unprecedented challenge that we're all facing. A little bit about my role, and I think why my friend Sharon asked me to help facilitate this conversation. I'm really proud at LCMC that we are partners with Tulane on many fronts as the teaching facility, University Medical Center for Tulane School of Medicine. And just, I have to say, throughout this pandemic, I've worked so closely with Sharon and others at Tulane on ways that we can just make things happen faster and better for the city as far as testing and providing care. So I'm certainly, although I'm not a Tulane alum, I wore my green today. And I'm really honored. I think it's an important topic to be discussing today, and thank you so much for having me. So I'd like to start off today with introducing a really fantastic group of panelists from the Tulane community that we have with us today, and we'll just launch right into some questions. So if we can, I'd like to start with Ms. Bonetta Horn, if you can briefly introduce yourselves for those who are joining us who may not know you.
Good afternoon and welcome. Thank you for signing in for our panel. I'm Bonetta Horn, Director of the Office of Multicultural Affairs here at Tulane University School of Medicine. This office was formally created in 2015, initially to focus on student diversity, to encourage the admission, retention, and support of underrepresented in medicine students. Expanded in 2018 to include faculty and administration as well, including training on things such as bias and cultural competency. And I just want to say that I'm happy to be here, happy to serve the Tulane community. We have a fantastic group of not only students, but also faculty and administrators. Thank you.
Thank you, and thanks for being with us today. Would like for Darren, Shang, and Allie from the Tulane School of Medicine class of 2023 to introduce themselves, please.
Go ahead, Allie.
Hi, everyone. Thank you so much for having me and for inviting us here. I'm really excited to have this conversation with you all. My name is Allie. I use she or they pronouns, and I'm a first-year medical student. I'm also the president of the Medical Student Pride Alliance, also known as MSPA, that represents the LGBTQ community at Tulane School of Medicine, and we do advocacy and community building.
Wonderful.
I'm Darren. I'm like Allie, I'm a first-year medical student. I'm the president of APAMSA here at Tulane, which is the Asian Pacific American Medical Student Association. And, really we've been active with, the Asian American population, whether it be East Asian, Pacific Islander population, Southeast Asian, and sort of just promoting advocacy for those populations.
Great, thank you. Thank you both so much for your advocacy and for being here today. And then Dr. Cheyenne Chakraborty, who I'm told many of your students know you as Dr. C.
Yes, yeah, Cheyenne Chakraborty. I do often get called Dr. C, which is totally fine. I'm actually at UMC. I was seeing patients today and may have to see some more patients this afternoon. I'm currently on the COVID team, so I'm right in the thick of things. Thank you for inviting me to this panel. I work pretty closely with Ms. Horn, and I've actually spoken at the Asian Pacific Student Organization meeting that they had earlier in March. So thanks for letting me participate.
Absolutely, and thanks for what you're doing at UMC. And then last but not least, Christy from the Tulane University Office of International Students and Scholars Director. If you'd like to introduce yourself.
Hello, everyone. So I'm the director of the OISS, and in that role, we're providing immigration and support services for international students, faculty, staff, postdocs, researchers. So pretty much everybody who's coming to Tulane and needs immigration and support services. Some of those support services include cross-cultural training and international education initiatives. And I'm also the advisor to the Tulane Chinese Student and Scholar Association, the South Asian Graduate Association, and the Tulane International Society. And I'm involved on campus with a lot of different issues of equity and inclusion, working closely with multicultural affairs. And in my personal life, I'm also on the board of Grodat Youth Farm, and we're often thinking about these same issues in the New Orleans community. And I want to thank everybody who has been working on this and who organized the panel today. Thanks for having me be a part of it.
Great. Well, we have a lot to talk about today, and would love to just kind of start by opening up with our first question, which is, and this is open for anyone who would like to respond. You all have different perspectives on this, but would love to know, if bias, be it race, ethnicity, sexual orientation, education, or other, has affected you in any way in your role at Tulane or in the medical education community in general. And again, open questions. So if any of you have thoughts to share, we'd love to hear them.
I think I'll jump in and start first. As the first full-time director of the Office of Multicultural Affairs, I'm kind of a one-stop shop in terms of student support. We have a lot of traditionally underrepresented in medicine student groups, whether that be based on race and ethnicity, religion, sexual orientation, socioeconomic status, or first-generation status, who are just basically trying to find their way in place here at Tulane. Historically, we haven't been as diverse as we would like, but lots have changed fast due to my efforts and efforts of the faculty and administration and also staff. In terms of students just wanting to find their way, we want our medical school classes to look like the world of the patient population that they're going to serve. We're in an urban city that has high populations of underrepresented or traditionally underrepresented groups, and we want the physicians coming in to not only be prepared to treat those populations, but feel welcome into the communities that they serve. There have been instances where students have come to me with issues where they felt like they were maybe being biased against in terms of in their, sometimes maybe in terms of curricular things, sometimes in terms of clinical services in the hospital. But we have worked to make sure that Tulane has become and or is becoming an open place. We have instituted bias training, cultural competency training, especially in terms of new faculty hires, new administrative hires, to make sure that everyone knows that Tulane is a place where diversity is not only welcome, enforced, but also valued.
That's wonderful. Well, thank you so much for your leadership in that area. I don't want to put you on the spot, but Christy, I know that your office provides so many resources. Do you have additional thoughts on things that are available for students and faculty, kind of piggybacking on what Ms. Horn was describing?
Well, to her point about the impact of some of what has been going on, over the years, we hear frequently from international students about both kind of bigger issues around bias or discrimination, but also smaller kinds of microaggressions. And I think that the hard thing is with some of this is it's a collective effort to really make change in this area. And like in this case, this is an incident that happened sort of outside of the Tulane structure. And so I think, part of it is a societal change. Part of it is how we prepare people to deal with incidents like this. I know in this case, it seemed like an extremely stressful situation, and the people involved handled it in a way that helped to de-escalate it. We hate to put the burden on the person that's being impacted, but that it did seem helpful that they were able to de-escalate the situation. I definitely don't have all of the answers, but I think, education and promoting cross-cultural understanding society-wide is definitely a part of it.
Yeah, I think it's great that you guys have so many resources.
I can speak a little bit to the student perspective on bias. I think that biases show up, like Christy was saying, that this is a cultural issue, and it certainly isn't a Tulane specific issue, but bias is incredibly pervasive throughout medicine in general. So for example, I'll see things that say like men need X grams of protein and women need Y grams of protein. And that to me is just, that is sort of like reinforcing these binaries that we already have. And it's really limiting our perspective to see someone as a full person. So, if someone like me walks into the clinic, I'm non-binary. So where would I fit? How many grams of protein would you tell me to eat? And so I think our biases in medicine are really sort of keeping us from being on the most cutting edge of scientific discovery and from really looking at the data that we have. I see this show up as far as race goes as well. So, we'll see on a slide, it'll say African Americans have higher rates of diabetes than white Americans. And that just sort of gets me thinking because, we know that race is a social category. It's not a biological category, and it's changed and fluctuated a lot over time. And so I just start thinking like, well, if this is a social category, then what are we not seeing in this picture? There's been some really incredible research looking at how racism impacts different disease processes, particularly diabetes and hypertension. And so when we think about bias, I think one of the things that sometimes is left out of the conversation is thinking a bit about it on a systemic level, thinking about the ways our institutions are still shutting out a lot of people and really prioritizing other people over that. Part of the reason why I'm in medical school, part of the reason why I think we're all drawn to this is because we're curious and creative people. And I would just really like to see some direct addressment of different biases so that we can be the best scientists and healers that we possibly can be.
Thanks for sharing that, Allie. That was powerful. And I actually have a kind of a follow-up question for you and for Darren. Being in the middle of your educational experience during this pandemic, I mean, have you guys seen, what would you say are the effects of COVID-19 on your clinical and educational experiences given the time we're in?
Well, I can speak to that on just as a personal experience that I've experienced in the hospital. So actually, since the School of Medicine switched to online instruction, I actually returned to the front lines to work in the ER and ICU, the old hospital that I worked in here in New Orleans. And I can tell you about an incident that really, really rubbed me the wrong way. And that was when, I was in the break room just grabbing a snack because, we were just getting slammed with all these patients. And a practitioner comes in and says, she was taking care of a couple who were Chinese. She just assumed they were Chinese. And this was months before the COVID pandemic had hit us, but she was adamant about saying they definitely had COVID, they definitely spread it. And it just really, really upset me to the point where I got up, left the room, and had to come back and calmly explain to her that just because they were Asian looking, you can't assume that they were Chinese. They could have been Japanese, Vietnamese, Korean, any Asian ethnicity. And you can't just assume because they were Asian that they were carrying the COVID-19 virus. And so, it's it's incidents like that where I was literally 2 feet away from her that sort of really just impacted me, because to see how overtly racist and discriminatory her comments were to somebody that she probably didn't even realize was in the room was just, it just baffled me. And it baffles me that, is still a common thing today. And so that's really, that's an experience that probably will resonate with me for quite some time, especially during this pandemic and moving forward.
Yeah, I mean, I commend you for saying something. Can I ask what was her response? Did you feel like it was a teachable moment for her, and you were glad you said something?
I mean, she was appreciative of my comments. I mean, they were definitely constructive comments, but I pretty much sort of laid it out for her and said that you can't just make assumptions or generalizations like that moving forward. Just because you treat an Asian patient shouldn't have any bearing on your course of treatment, just because of their race or their ethnicity like that. And so, yeah, she was appreciative of it. She acknowledged it. And I just hope, that's something that not only her, but, the rest of the staff sort of takes away. Because I mean, in an ER setting, you're seeing patients, for maybe 3-4 hours, and move them to the floor, and then you get your next patient, so on and so forth. And so hopefully, that sort of gets passed along. Hopefully that information, that message gets passed along.
Well, thank you for sharing that experience, Darren. Allie, I wanted to go back to you and ask how COVID-19 has impacted your educational experience during this time.
Yeah, I think it's really just shown me, as Darren was saying, how urgent it is to really be talking about all of these different social factors that have such a dramatic impact on health. I mean, here we are in Louisiana, where I can't remember the exact numbers, but something like 70% of the disparities between African American people who have died from COVID and other groups that have died from COVID is really striking and very, very troubling to me. And so what I would really like, I think the biggest thing as far as the curriculum goes is we really haven't talked about COVID that much. There's been, some talk. I think we're about to get into the viruses next week, actually. So don't quote me on that. But as far as looking at how our structures are shaping people's health, and particularly, I've been following some folks who have been doing work around disability justice, and especially people who are who are doing work to make sure that those folks are not being taken off of ventilators. And so really thinking about what is our role in medicine to ensure that everyone has an opportunity for safety and health, and that we as physicians are not making judgments based on what we value as, someone's life is more valuable than someone else's life because this person has a disability, or this person, has an intellectual disability or physical disability. So I just feel like we have a lot of work to do to really start to think about how we're going to create a healthcare system that is equitable and just coming out of this. And I do think that this is a moment where we can be really imaginative and creative, because systems are really crumbling right now. And I would really like to see a healthcare system that values and honors everyone's life.
Yeah, thank you both for sharing that. Dr. Chakraborty, from a clinical perspective, how has this impacted your clinical practice experience?
Well, most of my practice is inpatient, so I'm in the hospital. I don't actually have an outpatient clinic. So as an inpatient hospital-based physician, it's at one point 80% of our patients being admitted to the hospital were COVID positive, or as we say, patients under investigation, PUI patients. That number is probably down to about a third of our patients now, which, kind of correlates with the flattening of the curve that is presumably going on in this area, at least. So in terms of my personal clinical encounters, it's just been an increase in COVID positive patients, followed by now a gradual decrease in taking care of COVID positive folks. But I think follow up on a couple of things that Darren and then Allie both said. And this is, I think, going back a little ways, I think it's a very good point that Allie made about the example with men need X many grams of protein and women need Y grams of protein. And you're right, that does perpetuate gender stereotypes. And I think that is something to be pursued through more, a broader vision of what clinical research needs to address. That's absolutely the case. But in point of fact, if you were to ask, like, well, someone who identifies as non-binary, how many grams of protein do I need? My answer is, I don't know. We don't know as a medical science. And that goes back to the idea of, broadening the scope and the vision of what clinical science needs to investigate and pay attention to. And frankly, while I think it's starting to occur now, very, very slowly, it's going to be the next generation of clinicians and clinician scientists and epidemiologists and public health folks and anybody who's coming into any kind of contact with patients and their families to fill in those gaps. And there's no question that there are gaps. But from the actual clinical science standpoint, I don't have an answer for that. And not to say that that's okay to not have an answer. It's to say that we don't know, and I don't have a definitive answer for that. The other question, the other thing that I would want to follow up on is, so I finished med school in 2002. I finished residency in 2005. I was the last group of residents to complete their training at Charity Hospital. I went on and I did a fellowship in Baltimore. So I've been a practicing clinician since 2005. And unfortunately, we find ourselves occasionally, not all the time, but occasionally in that terribly, terribly unenviable position of having to value judge different people's lives, frankly. And that's no more starkly identified or brought into focus than current pandemics or other disasters or other, hyperacute responses that might be called for. I personally have had, in the last 3 weeks, had to be involved in discussions with multiple individuals, not the least of whom was the patient themselves, with respect to what are the best way to allocate limited resources. And, I fervently hope that you don't find yourselves in that position over the course of your clinical career. But all too often, we do find ourselves in having just that kind of discussion. And whether or not it actually is like, okay, well, this person has a more fruitful life ahead of them than that. I'm not saying it's quite so on the nose as that kind of discussion. But ultimately, when we're deciding questions about who needs to be taken off of a ventilator, who needs to be put on a ventilator, who needs to have goals of care discussion, underpinning all that are a lot of those discussions about, well, has this individual had a fruitful and valuable life up to this point, and are they realistically going to be able to resume a fruitful and a fruitful life? And that's always going to be a difficult question to answer. But we find ourselves in those situations, and it's not usually quite as black and white as I'm clearly saying this person is better than this other person. It's a lot more subtle and insidious than that. The last thing I wanted to talk about was somebody brought up, I can't remember which one of y'all brought up learning more about COVID. And I gotta tell you, the information that we're dealing with changes quite literally, not even hyperbole, every other day. At the early part of this week, we had a certain protocol for what we were doing for the hypercoagulable state that we're finding in our COVID patients. And by Wednesday, that was old news, and we had to review what we were doing for our hypercoagulability against the background of COVID infection. So it's a little hard to disseminate clinical information to learners and trainees when we're changing things on a 48-hour basis.
Well, I know I'm sure everyone who's watching this and in the Tulane community is super grateful for all the work you're doing on the front lines, Dr. C. Pretty incredible work. I am reminded to, if you are watching on Zoom or Facebook, you are welcome to submit questions for us. Would like to invite you to submit questions of the panel anytime. If you're on Zoom, use the Q&A function, and if you are on Facebook, through the live stream comment section, and we will do our best to get to them. Darren, I have a follow-up question for you based on the really unfortunate incident you were describing from a fellow student who was kind of based on the fact that, you know, there was a individual who had assumed that someone was Chinese when they were not. Do you or really anyone on the panel have advice on how anyone should handle that if it happens to them?
I think, you know, it kind of, and we were given a talk about this actually during a fin session just a couple months ago before all of this started, and it sort of boils down to, you know, obviously this was a practitioner who I had worked with for quite some time, and so I had a relationship with this practitioner. Like I had an understanding, I had a rapport, and so it seemed fine that I could approach her with this and talk to her about this, colleague to colleague, and explain to her it this way. But, you know, what do you do if it's an upper level attendant and you're just a resident or you're a med student? You know, how do you approach that? And that's always been the dichotomy between the two has always been a very tenuous one. And so, you know, it's tough. It goes to show, you know, how do you, you know, you got to pick your battles. And I think this was a battle that I chose to pick. And one that I think just needed to be settled, just based off just how egregious her assumption was. But I think it does depend. It does depend.
Thank you. I have a question for you, Dr. C, from someone on Zoom or Facebook, and it's, I think, very relevant just given what you've described on the front lines. Do you believe that universal health care could help remedy some of the disparities attributed to ethnicity or race that you've described and that you've seen firsthand?
I am a proponent of universal health care, so I'll say that right off the bat. I think universal health care is the way that we need to go, and for a bunch of different reasons, but that wasn't necessarily the spirit of the question. Yes, I think it will help in some ways, but I don't think it's going to necessarily solve the problem. Will it help? Yeah. Here's the conundrum that I see from a clinical perspective is, even if you, and there's an analogous problem that I'll get to in just a second. Even if you provide folks with, let's say it's like, you know, the dream goal of everybody gets free healthcare that they don't have to pay a cent for, you know, just pretending for a second. Even if that happens, that certainly removes some barriers for folks to seek healthcare, but there's still a motivational component on the part of the individual to avail themselves of healthcare, and that occurs in more than one way. not just to avail themselves of when they get sick, go see somebody, but also to have the mentality to start going to see a doctor regularly to prevent bad things from happening. And, you know, unfortunately, I don't believe that the American culture with respect to your personal health is in the same frame as some of the other cultures around the world where we don't necessarily seek care from a preventative standpoint. You know, I've made the comparison to folks in the hospital after I see them. I only see them in the hospital. I don't have a clinic practice again. And so when they get admitted to the hospital, there's something that has gotten to the point that to actually be able to take care of. So I make the point that part of our cultural fabric or society's fabric is you go and you get your oil change in your car every 5,000 miles, right? And most people do that because they don't want their car to break down and have a big repair bill. But that same mentality is not as well entrenched in the American society for yourself. Like, I need to go make a doctor's visit so that perhaps that'll prevent or minimize the impact of my familial diabetes or hypertension or my hyperlipidemia. It's just when they start having chest pain or they're having numb fingers, they come in. And so when people feel well, they don't want to go to the doctor, right? That is heart and soul, the foundation of preventative care. Come see the doctor when you are feeling well. And that doesn't tend to happen. You go to the doctor when you get hurt or you get sick. And so, yes, universal healthcare will help, but I think the other self-motivational part of it needs a lot more work.
It's such a good point. And, you know, what we're seeing in so many parts of the healthcare system, obviously everyone has been really focused on the COVID pandemic, but there, you know, we do worry about the vulnerable population right now being able to access that preventive care because they might be worried about social distancing or because the clinic that they usually go to is closed or has reduced hours. So it's thank you for sharing that. It's a good segue to one of the next questions, which is, you know, curious if you guys think that the social distancing has had an impact on bias in any way thus far, and if you think it will in the future.
Do you mean generally or in a medical setting?
In general, or specifically in a medical setting.
I mean, I guess generally it seems that when people are afraid or sort of feeling concerned, that they can be more likely to go toward stereotypes or, you know, fear of other people. But I think we also see a lot of instances of the community coming together and supporting each other. So it's probably, from what I've seen, a mix of both in general and society.
Anyone else have thoughts on that? I mean, we're in such an unusual time, right? And just the impact that social distancing and stay-at-home orders might have on bias.
I have a thought about it. I think that I thought that social distancing in southern Louisiana would no way ever work. And so I really have to, just because of what we do in New Orleans and in southern Louisiana, which oftentimes is pretty cross-cultural. We congregate with friends and family, and frankly, we find any excuse to congregate. I've been actually pretty impressed by my fellow Louisianians about their ability to socially distance appropriately. Now, it hasn't been 100%. You always find yourself in the grocery line. It's like, whoa, buddy, back off a little bit. But for the most part, I think I've been pleasantly surprised and proud of the way that we've been able to achieve social distancing in Louisiana. And frankly, I don't think that we'd be seeing the flattening of the curve that we appear to be experiencing if that hadn't occurred. And, we're about to, I guess the nation's about to launch in the experiment with Texas and Georgia freeing up some of their restrictions. And we'll see if they start to see a little bit more of a surge. I mean, I'm not hoping for that, but certainly that is the risk that they're, the risk that they're taking by relaxing some of the social distancing restrictions.
Right. Thank you, Dr. C. Want to ask sort of a non-COVID question, again, open for anyone, which is, what has been the largest obstacle in your identity group? And really neat, we have such a diverse group here today, but, in your identity group, what's been your biggest obstacle in facing bias, if you would like to share that with us and for those watching?
I'll respond to that in terms of my identity group, and I think that's kind of a loaded statement in itself because I don't think that I possess one group at all. I'm a firm believer in intersectionality, so you just can't look at me as a woman or just look at me as being Black or look at me as working and affiliated with the medical school. So I think when you consider anyone, you need to consider all the identities that they bring to the table. I'm often in situations, particularly here at Tulane, where I may be one of the few females in the room, maybe one or the only person of color in the room. I'm also at times maybe the only person that's not terminally degreed in the room. So I think that everyone brings their own biases to the table, and I work very hard to make sure that people don't make assumptions. Don't assume that just because I'm one or a couple or all three of the things that I just mentioned, that I don't bring a good contribution to the table. I don't have to be a physician or be a PhD to kind of plug into the needs of the School of Medicine in terms of diversity, equity, and inclusion. But at the same token, because I am a woman or because I am underrepresented ethnically at the medical school, I bring unique characteristics that may help and show that all of my identities should be welcomed and received in this community. So working hard to dispel bias, working hard to work on our community being more culturally competent and to be more welcoming and receiving and let everyone know that there's a seat at the table for everyone and that we welcome you to bring all the identities that you have to contribute to making our school a better place.
Thank you, Benetta. Anyone else have thoughts to share on that? If not, I have a specific question for Christy. What resources do we have to help our international students as they deal with bias? If you'd like to describe a little bit about that.
Yeah, so for any member of the Tulane community, there's a bias response team that is available to deal with any incidents. There's a website called Tulane Concerns that is available for anybody who wants to report something. You can report it anonymously. Of course, it's harder to follow up if it's anonymous, but sometimes people, if it's a graduate student reporting an incident with their advisor, they may feel that they're not comfortable to disclose their identity. But in general, whether you disclose who you are or not, the bias response team will take a look at the incident and take appropriate action, also working with the Office of Institutional Equity and other folks on campus. I would say that's the biggest way that Tulane responds to incidents of bias. there's a lot of concerns that I hear about in the classroom, and right now being online, there was some concern about how academic issues might be dealt with professors and international students being in different time zones and things like that. And so Tulane has a special form for reporting academic issues, and that can include bias or just any other kind of academic issue that's happening because of classes being online. And again, I do think Tulane tries to respond. It can be, students don't always feel satisfied with the response, and some situations are very complicated. But I think Tulane tries, and we also have an exciting, announcement that just happened. I believe it was this week, with our new position that's going to be focused on diversity issues. And I think we can expect to see a lot more progress in this area with that new position.
That's wonderful. Thanks. Christy, what was the name of that website again? And does everyone know how to get it? You said it was Tulane Concerns.
Yeah, if you just Google Tulane Concerns.
Okay. That makes it really easy. Thanks for sharing that. Okay, I have another question, and this is open for everyone. Have any of you experienced personal bias in your gender, race, ethnicity, or other from a patient you were caring for, or a colleague at work, or a student, or a professor? Darren shared his personal experience previously, but would open it up to any of you guys if you've had any of those experiences, and if you did, the person is also wondering how you addressed it.
I can speak to another one that happened that very week of a different patient that I was caring for. And so, a patient comes in, experiencing the symptoms of COVID-19, and, as part of the team, both the nurse and I and the physician go in to assess the patient. We gown up, put our masks on and everything. I go to hook the patient up to the EKG machine, get the IV stuff ready, and I'm ready to stick her and put an IV in her to draw her blood work. She asked me to stop. And I said, are you uncomfortable? Is there anything I can do for you? She proceeded to ask me, where are you from? And I said, I was born and raised here, and here in America. And then she goes like, no, where are you really from? I'm like, well, my parents are from Taiwan. I was born in California. I came here for school. And she's like, and then she said, can I have somebody else, draw my blood work? And I'm like, okay. Is there a particular reason why? And she simply just said, with all this COVID stuff coming from China, I'm simply just worried the fact that you look Asian. I just don't want to take any chances. And so I removed myself from the care team, stepped out, and had another person come in and draw her blood. And so at that point in time, I had to make a split-second decision. I had to do what was right for the patient and make the patient as comfortable as she could possibly be. And again, we were backed up on staffing. And so, I just go into all the rooms and just start seeking people to draw their blood work, get them done as fast as I can. And so that was just something I had to bite the bullet and swallow. And at the end of the day, I came home and said, wow, that really rubbed me the wrong way. But, it goes back to what I said earlier, you kind of have to, in a time like this, it was tough. I had to pick and choose my battles. And that was a battle that I decided to not pick with the patient, given that the patient was in distress. And I said, you know what, I'm going to do what's best for the patient, and I let somebody else take care of it. So that was one that happened a few weeks ago for me.
So I have a similar, but I went in the opposite direction. So I'm frequently mistaken for being Latino, usually Mexican, because and I had a kind of similar encounter where they mistook my ethnicity and kind of asked and they were also in distress, and they were like short of breath and like, legitimate in distress, and they wanted they were asking if they could find a different physician. And I pointed out, it's like, listen, I could go screw around and try to wrangle up a different physician, or you can work with a physician who's right here in front of you and willing to help you in the next 30 seconds. your choice. I hope you don't make the wrong one.
Mm.
And that was, I think, perhaps a little me taking advantage of the situation and leveraging the urgency that the patient was in. But I basically called out that, like, hey, I can screw around or I can help you.
Wow. Wow. That's so difficult because, of course, you both in both of those situations we're simply just trying to provide the best care and to help. That's really unfortunate.
I'd add that, it's I'm not saying that I did the right thing. I will acknowledge that I was in a different position compared to Darren, presumably because given our relative degree of being a veteran in our respective roles. So as a senior clinician, it was easier for me to go that route. Whereas, and I think both Allie and Darren kind of alluded to this in one of the earlier comments they made, was that, as a trainee, well, what if it's what if the person who is coming at it from a biased perspective is someone in an authority role. And yeah, that's challenging. And I can tell you that as a clerkship director, and I'm the internal medicine clerkship director, so every last Tulane medical student at some point or another will roll through my clerkship, since it's a core rotation. And I know that I can speak for all the other clerkship directors to say that it's entirely, we view this as entirely our job to shield students, our learners, our trainees, from any kind of repercussions as the clerkship director, from feeling that they need to challenge the hierarchy. And a lot of us talk about flattening the hierarchy, and there's always, it always sounds good to hear that, but I think it also sounds good to hear that it's my role as the director of the clerkship to try to prevent and minimize or eliminate any repercussions. But I know that that's always going to be sort of an omnipresent concern, no matter to what extent I say and can actually try to minimize and obviate any repercussions. It's going to be an all omnipresent thought on the part of the junior learners.
Yeah. And I can't remember, it may have been you, Dr. C, who mentioned kind of Tulane's focus and just this need in general for training that next group of providers to really look like the populations that they serve, and being, underrepresented. And I'm curious, I assume the answer is yes, but for Allie and Darren, do you feel like the Tulane School of Medicine environment is in fact open and welcoming to those who are underrepresented in medicine? And would love to hear more from you about that.
Go ahead, Allie.
I think that we are moving in the right direction. I can speak only from my personal experience and say that there have certainly been times where I have felt, I wouldn't go so far as to say unwelcome, but I have felt at odds with some of the things that we're learning and the way that things are done in the curriculum. And so I'm reminded of this quote by Abraham Herschel. He said, "Few are guilty, but all are responsible." And so I think about that a lot and think about how, it's all of our responsibility to reduce bias and to create both a learning environment and a healthcare system that is really going to be spacious enough for everyone to be their full selves. Ms. Horn was alluding to this earlier, but I think when we think about what an ideal learning environment would be, to me, it's not so much about bringing everyone in closer to some norm. It's about creating enough space where people can be their full selves and can be all of their different identities and can really show up honestly. And I think in allowing learners, trainees, physicians, staff to be their full selves, it will mean better outcomes for our patients and a really stronger healthcare system. And I feel that also with what Dr. C was saying about in terms of preventive care. Like, I think thinking about this like spaciousness model and offering a lot of different options for both our learners and for patients, so that people can really find what resonates most with them, and like I said, can just be really sort of honest in who they are.
Thanks for sharing that, Allie. We actually have a specific follow-up question for you from Facebook, which is when considering LGBTQ issues, this person says that people often feel like there may not be issues because we're in New Orleans. I guess they're assuming because we're a progressive city, but I'd like to know from you if you feel like that's the case.
So I just want to acknowledge also that I'm speaking from the perspective of being a white queer person, and just sort of acknowledging that, you know, my queer and trans siblings who are people of color experience different axes of oppression. And so I can really only be speaking from the perspective as a white person. As far as like sexuality, I think that there is sort of a broader acceptance, particularly in New Orleans. But if you drove about 20 minutes away from here, it would be a really different experience. And I still think that even among my classmates, there's sort of a lack of knowledge just about like basic terminology. So like I said, for example, I refer to myself as queer, and I had a classmate ask me what that meant. I didn't think of that as something, you know, negative or that they were being discriminatory, but it just surprised me that we didn't even really have like a common language about different ways that people refer to themselves. I would say that as far as gender identity goes, there still is a lot that we need to be doing to be supporting our trans and non-binary communities. You know, Black trans women have, you know, the mortality rates for Black trans women is really, really devastating. You know, being a 40-year-old Black trans woman is considered an elder because of the high rates of violence against that community. So when I think about sort of the queer community that I claim, I'm sort of, again, coming at it from this point of spaciousness and really thinking about how can I make sure that everything that I'm doing, because of the privileges that I have as far as education and race go, to make sure that I'm advocating for all of my queer and trans siblings.
Thank you for sharing that, Allie. Ms. Horn, actually have a question for you, which is if you can share a little bit about what Tulane is doing to recruit Asian or Asian American students who may be reluctant to join the Tulane community.
Sure, happy to answer that question. In terms of what we're doing for Asian Americans, it's kind of what we're doing for all of the underrepresented group. We're being intentional about our recruitment, retention, and support. We are seeking out applicants and sort of meeting them where they are. We're privileged that we are located very close and have a close relationship with Xavier, University of Louisiana, literally less than a 10-minute drive. Fortunately, I'm a Xavier alum, and I have a close relationship with the pre-med office there, and their Asian American population has been growing steadily. We have an early assurance agreement with Xavier where students can apply as sophomores and also be given conditional acceptance to the medical school. And acceptance into that program gives them a relationship with my office and with the admissions office directed by Mr. Mike Woodson, where we kind of meet them at a sophomore level and kind of coach them all along. I also have a good relationship with the PAMSA Association, was privileged enough to participate in the regional conference that they held and had or have plans to try to attend for the first time the national PAMSA conference, where we can do what we do similar for other groups, go to the recruitment fairs, go to the conferences, and get our boots on the ground in terms of meeting students where they are and letting them know that not only is Tulane open for business, but that they are welcome and encouraged to apply. But we don't stop at the application point. We not only want you to apply to Tulane, we want to do what we can to help you be accepted and then support you once you're here, to let you know that groups like a PAMSA and faculty are here to support you while you're here. So yeah, things like that are ongoing, and hopefully we can advance them and see good progress.
Great, thank you for sharing that. And believe it or not, we have only 5 minutes left. There's so much to discuss here. The time has really flown. So would like to kind of start with closing out with final thoughts. And to do that, I would like to ask each of you the same question, which is, what keeps you up at night about this topic of bias, and what gives you hope about this topic? And I'll go first. So I have a daughter who is biracial. She's 2.5, actually almost 3. And you know, one of the things that keeps me up at night is, are we collectively working toward a better future for her and any child who is biracial and a minority, you know, and all of the identity groups that she will associate herself with. And it's weird because at the same time, it's also what gives me hope, right? I mean, I am optimistic about the kind of person that I'm helping to raise, just based on what I'm seeing so far, and you know, that her generation, and honestly, and Allie and Darren, you guys as sort of the next generation of physicians, gives me so much hope. So thank you so much for what you shared today. And we'll just open it up. If anyone else would like to go next, what keeps you up at night and what gives you hope on the issue of bias?
I can go. So I think, you know, what keeps me up is seeing, you know, over the last years, increased numbers of, you know, incidents of bias and xenophobia in the US, but also worldwide, with growing nationalism and, you know, those kinds of things. And then I think the things that give me hope are knowing that there are ups and downs on the way to progress. So progress isn't just a straight line, you know, upward. And so hoping that this is just a moment when there's a bit of a drop. And I think COVID-19, which it's hard to say there's anything hopeful about it, but I think one thing that's hopeful to me is seeing the way that our society can make huge systemic changes when we're motivated to do so, you know, whether that's, you know, having more of a safety net for people that need it, with healthcare and economic support, things like that. So I guess that gives me hope that we can see ways that we can really change our society if we're motivated.
I'll go next. I'll follow up on that. Those are very similar to the things that I was going to say. I was going to say a closed-minded society, and we have seen, you know, some evidence of that, as Christy mentioned. Thank you. I was also going to point to COVID to make one point that, you know, the disparities, that the number, 70% number that somebody threw out earlier, while that's absolutely true, it's not like we just woke up and learned about that. Maybe the rest of the country just woke up and realized that. But these have been systemic disparities that have been going on for generations. And the fact that, you know, COVID might have brought that into a little starker focus and a little bit more attention great if there's an upside to COVID. And maybe that will continue to be a focus. And that's part of what gives me hope, as well as, you know, the folks who are participating and organizing and are in the audience for this kind of call. The change is going to happen one retirement at a time. And it's going to be the new wave of individuals who have a completely different mindset than the old wave of individuals that's ultimately going to bring us kicking and screaming into a whole new world. And I, for one, am looking forward to it. I'm tired of crossing off countries that I can't relocate to if I have to.
I'll go ahead and, go ahead.
I'll just jump in really quick and try to be short. Things that keep me up at night, probably making sure that I'm able to do enough and to affect enough change, not only here at Tulane, but in society, and also making sure that my students are okay. I think both Darren and Allie can kind of let you know that I take them personally, and I want them all to be okay no matter what is going on with them, whether that's educationally or financially or what have you, and that I answer personal phone calls on my cell phone all times of day and night. That also gives me hope, because the future is very bright. I hope that I'm encouraging them just like they encourage me, and to know that change is coming. And like Dr. C said, one retirement at a time, we can change minds, change the focus.
Yeah, I sort of just want to attest to what Ms. Horn said. She's absolutely right. She definitely cares for each and every one of us like we're her children, and kind of want to echo what Dr. C and Chrissy both said. And actually, this just came out in the APAMSA newsletter just a few hours ago, and I can't really articulate this any better. But what keeps me up at night is that currently, as an API student, there have been numerous reports of racially motivated hate crimes and prejudice within the country and all over the world. That really disappoints me greatly. And we as Asian Americans are once again reminded that we are the model minority, but also the yellow peril as well. And historically speaking, for those that know that, history just tends to repeat itself, and these are two sides of the same coin. And really what I'm optimistic of is that all we can do is, sort of keep educating others and raise awareness and improve things until one day, racism is the non-existent abnormality. And that was directly quoted from a newsletter, and I could not articulate that any better. And hopefully one day, this town hall itself proves that, change is coming and that we are raising awareness for things like this.
I'll just say, yeah, I first just want to thank all of you so much. And it's really been an honor to be in conversation with everyone here. I would say that what keeps me up is just how deeply entrenched and really generations, things like white supremacy and ableism are. We're up against a lot, but the flip side is that there feels like there's really been an explosion of solidarity and community over the last couple of months, and in seeing the ways that like we as humans naturally have an inclination to take care of each other. And I felt really loved and cared for by a lot of people in my community, particularly people in the Tulane community over the last couple of months. And I think if we can keep building from that place of solidarity, we can really change the world.
Well, thank you guys so much. I know, speaking as your health system partner and just a member of the community, the Tulane community is very lucky to have all of you as members and leaders. So thank you so much for participating today. Thank you, Tulane, for hosting this conversation and encouraging this conversation. And thanks to everyone who's joined on Zoom and Facebook today. And we'll look forward to the next one.
Thank you. Take care, everybody.
Thank you.
Thank you.
Thank you.